Hello everybody, my name is Eric. What we're looking at today is non-bacterial thrombotic endocarditis. Definition of it is that it can be shown as the MBTE, caused before the hemorrhagic endocarditis. It refers to the spectrum of lesions ranging from microscopic aggregates of platelets to large vegetations and previously damaged heart valves, most often aortic and mitral in the absence of bloodstream bacterial infection.
Non-bacterial thrombotic endocarditis, NBTE, is a form of endocarditis in which small sterile vegetations are deposited on the valve leaflets. Formerly known as merantic endocarditis, which comes from the Greek merantikos, meaning wasting away, the term merantic endocarditis is still sometimes used to emphasize the association with a wasting state such as cancer. Risk factors. Merantic vegetations are often associated with previous rheumatic fever. Other risk factors include hypercoagulable states, malignant cancers, especially mucin-producing adenocarcinomas, most commonly associated with pancreatic adenocarcinomas, systemic lupus erythematosus, referred to as Liebman-Sachs endocarditis, trauma, e.g., catheters. Valve predilection. The disease affects the valves with the following predilection: mitral valve, aortic valve, tricuspid valve, pulmonary valve. Histopathology. Grossly, vegetations form along lines of valve closure and are generally symmetric with a smooth or varicoid, warty, texture. Histologically, lesions are composed of fibrin, eosinophilic, and platelets but, unlike bacterial etiologies, contain little evidence of PMNs, microorganisms, or inflammation. Diagnosis. Due to the non-invasive nature of NBTE, clinical examination may or may not reveal a new murmur. An embolic stroke may be the first feature to suggest the diagnosis of NBTE. An echocardiograph may be used to further assess for valvular lesions.
Please subscribe and thanks for watching.
The applications in medicine, physical therapy, nutrition, neonatology. Diagnosis of NBTE relies on strong clinical suspicion in account of a disease process known to be associated with the NBTE, the presence of a heart murmur, negative blood culture, the presence of vegetations not responding to antibiotic treatment, and last but not least, an evidence of multiple systemic embolia.
Endocarditis used to be classified into groups, like acute and subacute, based on how quickly the infection developed. But nowadays, the key is to identify the microbial cause of infection and to treat it as effectively as possible. Viridans streptococci is the most common cause. Its virulence is low, it's found in the mouth, and they usually attack valves that have had some previous damage, usually resulting in small vegetations which don't destroy the valve. Staphylococcus aureus, on the other hand, is a highly virulent bacteria that can be found in the skin. And this guy can infect both damaged and healthy valves, often the tricuspid valve. Staph aureus causes large vegetations that can destroy the valve, and is the bacteria most commonly contracted from intravenous drug use. Next, we have Staphylococcus epidermidis, which is a bacteria that loves foreign prosthetic material, like prosthetic heart valves. One way that the bacteria gets into the body is at the time of heart valve surgery, and it literally sticks around on the valve. Another common point of entry into the body, though, is through an infected intravenous catheter. Both of these scenarios usually happen in a hospital, so this would be considered a nosocomial infection.
Pros and cons. In a recent study of cancer patients with recurrent venous thromboembolisms compared low molecular weight hairpin and oral anticoagulation to find out that the ones that have low molecular weight hairpin have less recurrent venous thromboembolisms, and the probability of having a recurrent thromboembolisms at 6 months to be reduced compared to oral anticoagulations. In cons, we got that even with an established diagnosis treatment of NBTE is difficult. Corrections of the underlying causes of paramount importance in patients with advanced and non-prevalent cancers. Surgery is unlikely to influence the final outcome and also recurrent embolization.
Were updated in 2007, and the rationale to update these guidelines were that endocarditis is much more frequently to result from the random things you do every day than from the bacteremia associated with dental procedures, GI procedures like colonoscopy, the routine screening colonoscopies, or GU, which is cystoscopies and stuff like that. Prophylaxis itself prevents an exceedingly small number of infective endocarditis, if any, if it has any validity in dental, GI, and GU procedures. And then the risk associated with taking antibiotics typically outweighs the benefit, except in high-risk populations.
Conclusion: MVT is not a common entity, but is frequently underestimated, probably due to the underlying disease, cancer, autoimmune disorders, HIV, and it's difficult to diagnose and relies on strong clinical suspicion. It is difficult to manage, and each case should be individually managed by identifying and treating the underlying pathology. Surgical intervention is not recommended unless the patient is in acute congestive failure.
Hello friends, in this video, we will cover important topic for NEET PG image-based questions, which is different types of vegetations and their characteristics. This topic can be asked in pathology section as well as in the medicine section. Basically, there are 4 conditions you need to remember which produces vegetations around the heart valves or leaflets of valves. They are rheumatic heart disease, infective endocarditis, non-bacterial thrombotic endocarditis, and Liebmann-Sack endocarditis. The first MCQ point is, in Liebmann-Sack endocarditis, most common valve affected is mitral valve followed by tricuspid valve. But in rest all, most common is mitral followed by aortic valve. So we can say that in Liebmann-Sack endocarditis, there is mainly atrioventricular valve involvement. Now we will compare different types of vegetations. First is rheumatic heart disease. As you can see in this image, vegetations are very small, firm and friable and present along the line of closure. And vegetations over here are sterile. Next is infective endocarditis. Here, vegetations are large, bulky and irregular, present on the valve cusps and mural endocardium. Vegetations in infective endocarditis are non-sterile, and also they are most common vegetations to embolize. Next is non-bacterial thrombotic endocarditis, which is also known as mesenteric endocarditis. Here, vegetations are sterile and bland along the line of closure. It is usually associated with hypercoagulable state. And last is Liebmann-Sack endocarditis. It shows vegetations on either or both sides of the heart valves, that is upper and lower surface, but mostly they are present on lower surface of the valves.
So for now, thank you for the time and attention.